If somebody were to call 811 and request transport to a public institution, if it's medically appropriate, we'll do that. So to that extent, we do have that. But the vast majority of what we do, greater than 95% of our cases, go to a public institution. It's going through a considerable amount of change now, and it's a health system that is under tremendous pressure, but also under a sort of continuous change. And I've seen considerable improvements in the time that I've been here. Locally, chronic non-communicable disease is close to an epidemic, and current estimates from the University of the West Indies are that 80% of the population is either presently inflicted with a chronic disease or is at risk to develop that, in the very near terms, perhaps in the next decade of their life. And so that's going to create some additional, it already has, pressures on the health system. There's 3,750 hospital beds in a country of 1.7 million people. To care for those people in the institutions, it would require construction of a hospital on every street corner. And so we're going to need to come up with alternative methods to provide care for chronic disease. We're attempting to position ourselves now in increasing the clinical competency of our staff is to be part of that solution to rationalize how healthcare is distributed and accessed. Is that, we handle somewhere around 75,000 medical responses annually. By our estimation, approximately 30% of those are low acuity cases that probably don't need to be seen in an A&E and could be managed outside of the hospital. And so this requires some integration between the emergency medical service and the primary care system. This is being experimented around the world in many different ways. An optimal model has not emerged, and so there's a great deal of experimentation taking place. But I see that's our role in terms of how we can contribute to creating the fluid capacity that's necessary for what the future health demands are going to be of this populace.